Welcome back, everyone. Today, we are diving into the powerhouse of the upper limbs plumbing, the axillary artery. I'm pumped because if you don't understand this vessel, you're basically flying blind during a shoulder surgery or an emergency trauma case. It's the highway that keeps the arm alive.
Energy is high as always, Dr. Khan. But let's set the academic boundaries first. For the boards, you absolutely must know the start and end points. The axillary artery is just a name change. It begins as a continuation of the subclavian artery at the lateral border of the first rib and ends at the lower border of the teres major muscle, where it becomes the brachial artery.
Exactly. It's like a road that changes names when it crosses a county line. But here's the clincher. We don't just look at it as one long tube. We divide it into 3 parts. And the landlord of the axilla, the muscle that decides these boundaries, is the pectoralis minor. It literally sits right on top of the artery like a bridge.
That's the high-yield landmark. Part 1 is medial to the muscle, Part 2 is deep or posterior to it, and Part 3 is lateral to it. And here is the rule of numbers for your exams. Part 1 has 1 branch, Part 2 has 2 branches, and Part 3 has 3 branches. Simple, elegant, and highly testable.
I love that rule. Let's look at Part 1. 1 branch, the superior thoracic artery. It's the little guy. It supplies the first 2 intercostal spaces. Why does this matter clinically? Well, in the grand scheme of a massive trauma, it's small, but it's the first sign that you've moved past that first rib into axillary territory.
Moving to Part 2, deep to the pectoralis minor, we have 2 branches. First, the thoracoacromial artery. This one is a trunk that immediately fans out into 4 branches. Think of the mnemonic Chap D: clavicular, acromial, pectoral, and deltoid.
I call the thoracoacromial artery the Swiss Army knife of the shoulder. It's short, stubby, and hits everything in the neighborhood. But the second branch of Part 2 is the real clinical MVP during breast surgery, the lateral thoracic artery. It runs down the lateral side of the chest.
Precision matters here. The lateral thoracic artery is a major supply to the female breast. During a radical mastectomy, surgeons have to be incredibly careful here, not just because of the artery, but because it often travels with the long thoracic nerve. Dr. Khan, why does that relationship matter clinically?
Oh, that's a nightmare scenario. If you nick that long thoracic nerve while trying to control bleeding from the lateral thoracic artery, your patient wakes up with a winged scapula. They won't be able to push a door open or comb their hair properly because the serratus anterior is offline. You want to be the doctor of choice for your patients, not the one explaining why their shoulder blade is sticking out like a bird's wing.
Very true. Now let's move to Part 3, lateral to the pectoralis minor. 3 branches here. First is the subscapular artery, which is actually the largest branch of the entire axillary artery. It quickly divides into the circumflex scapular and the thoracodorsal arteries.
The subscapular is like the backup generator. The circumflex scapular branch goes through the triangular space and joins a massive network of vessels around the back of the scapula. This is the collateral circulation. If the main axillary highway gets blocked slowly over time, these side streets around the shoulder blade can actually reverse flow and keep the arm from dying. It's nature's way of building a detour.
And the final 2 branches of Part 3 are the circumflex humeral arteries, anterior and posterior. They form a ring around the surgical neck of the humerus. On the exams, they love to ask about the posterior circumflex humeral because it travels through the quadrangular space with the axillary nerves.
Let's talk real life. A 64-year-old woman falls down the stairs, like in the text, and has a subcoracoid shoulder dislocation. The head of the humerus isn't where it belongs. It's shoved down and forward. What's sitting right there in the line of fire? The axillary nerve and that posterior circumflex humeral artery.
Precisely. If she loses sensation over her lateral shoulder, that regimental badge area, you know the axillary nerve is compressed. And if that artery is damaged, you might see significant swelling in the axilla. It's why checking the pulse and sensation after a dislocation is non-negotiable.
And don't forget the funny bone of the shoulder, the surgical neck of the humerus. It's the most common site for fractures in the elderly. A break there is like a wrecking ball hitting the axillary nerve and the Part 3 branches. Why does this matter clinically? Because if you miss a vascular injury there, the patient could lose the limb while you're busy staring at the x-ray of the bone.
To wrap this up for the students, remember the boundaries, first rib to teres major. Use the pectoralis minor to find your 3 parts. Follow the 1-2-3 rule for branches. And always associate the posterior circumflex humeral with the surgical neck and the axillary nerve.
Spot on. Anatomy isn't just a list of names. It's a map of where things can go wrong. If you know the map, you can save the patient. Great session, Dr. Sarah.
See you in the next lab, Dr. Khan.